Hello and good afternoon. Welcome to NDARC's webinar this afternoon on this sunny Thursday afternoon. I'm very pleased to be your host today. My name is Sarah Feinbach. I'm a research fellow here at NDARC. And I'd like to, just before we begin, take a moment to show my respect and to acknowledge the traditional custodians of the land from wherever you're dialing in from. Today, I'm dialing in from Ngambri and Ngunnawal country, and it's a beautiful sunny day. And the webinar today has been hosted from Gadigal land. So welcome wherever you're joining us from today. Before we get started, I'm just going to cover a little bit of housekeeping and talk you through how we're going to run today's session. Today we have a guest speaker presenting from outside of NDARC. We're really lucky to have Professor Leanne Hydes, who wears several hats, joining us today. Leanne works at Lives Live Well in the Drug and Alcohol and Mental Health team based at University of Queensland. She's also Deputy Director of the National Centre for Youth Substance Use Research and is Director of the NHMRC CRE, Meaningful Outcomes in Substance Use Treatment. So Leanne's a clinical psychologist. She has over 25 years experience working in clinical and practice roles. And today she's going to talk us through some of her work, which covers different models of funding for health services, including value-based healthcare. So certainly an emerging area, something I'm interested to learn about myself. Her presentation today is titled Using Technology to Implement Client-Reported Core Outcome Measures with Feedback into Alcohol and Other Drug Treatment Services. So after Leanne has finished her talk, we'll be lucky to be joined by a panelist, Dr. Robert Sterling, who will address some of the ideas that Leanne's presented, and we'll have a bit of a chat amongst the panel before we do Q&A. So this is the important bit for Q&A questions. If you put them into the Q&A function at the bottom of your screen in about the middle, then we'll try and capture and tackle as many of those questions as we can before 4 o'clock. So enough from me. I'll just invite Leanne to welcome us. Hi, Leanne.
Hi.
Turn on your mic. Are you ready to go? Oh, now you've muted yourself.
All right.
There you go.
Oh, it's already on, I think. Yep. All right.
Over to you, Leanne.
Thanks, Sarah. Good afternoon, everyone. It's lovely to be here today. As Sarah said, I'll be talking about some of the work that we've been doing for the past 7 years, looking at how we can implement client-reported outcome measures with feedback in drug and alcohol services, and how we've used technology to enable that. Oops, there's a bug. All right. First of all, I'd just like to acknowledge the traditional owners and the custodianship of the lands in which we're all meeting today, and pay our respects to ancestors and their descendants who continue cultural and spiritual connections to country. We recognise the valuable contributions to Australian and global society. So I'm probably preaching to the converted here today. We know that drug and alcohol use is really costly. So KPMG did some modelling in 2021 showing that it's costing the Australian economy $80 billion. We also know from global burden of disease data that it's the #1 risk factor for death and disability across all age groups. So this really highlights the importance of the delivery of cost-effective and evidence-based treatment as a way of trying to reduce this cost and burden. However, this is quite challenging. The Australian drug and alcohol treatment sector, there's a huge demand. So in 2021, they saw 140,000 clients, and that was a 20% increase from back in 2014, 2015. And we know that the treatment needs of between 44 and 73% of people with current substance use disorders are just not being met. So there's this huge demand for treatment, greatly outweighs the resources available. And that kind of results in the volume of service delivery or the number of clients being seen tending to be prioritised over quality, just because there's no choice because there's such high levels of demand. And this is across both the government and non-government sector, where we've got this huge demand and limited resourcing and a huge unmet need. So we've been looking at value-based healthcare over the last couple of years, and this is a model of service delivery that shifts the focus away from the volume of service delivery towards client values or outcomes. So routine outcome measures are at the centre of value-based healthcare, and what we do is we identify them. We identify what outcomes matter to clients, with clients, and the staff involved. then the process of implementing the core set of outcome measures and then using those measures to monitor outcomes, provide feedback to clients on how they're progressing over time and hopefully improve outcomes. And then we use this outcome measure data to improve the efficiency, outcomes and cost effectiveness of treatment. So that reduces the demand for treatment and increases the quality of care that's being delivered. And that's been shown to optimize service delivery in cancer, cardiovascular disease and mental health in overseas studies. And the good thing is that the resulting outcome measure data that's collected can be used to evaluate different treatments. Oops. I don't know why an alarm's going off. And then fill some gaps in the evidence base. So the aim of today's talk is to describe how technology can be used to increase the uptake of these core outcome measures in drug and alcohol services. I just wanted to acknowledge that this work was not done alone. It was done in partnership with Lives Live Well over the past 7 years. So the huge team at UQ and the huge team at the Lives Live Well and also the National Centre for Youth Substance Use Research Centre was all involved. And just wanting to acknowledging the funding that we've received through the Australian Government Department of Health, through the National Centre for Youth Substance Use Research at the NHMRC, and of course Lives Live Well itself. And also the people with lived experience who have participated in everything we've done. We really value their contribution. So a little bit about Lives Live Well. So they're a Queensland-based service, which has expanded into New South Wales and recently South Australia. They have 188 programs delivered by about 500 staff. They treat typically approximately 15,000 clients a year or 300 clients a week. And we know from their outcome measures data and their clinical data that clients tend to generally attend about 1 to 2 sessions. So the services include 8 residential services, residential, detox, all sorts of services. And what we wanted to do, the first thing we wanted to do was sort of figure out what are the outcome measures that matter to clients and staff in this context. And that Lives Live Well were already doing some routine outcome measures when we came along. And what we wanted to do was just map onto these dimensions, which ones were the most important to them and to the clients themselves. So for drug and alcohol measures, we're using the Australian Treatment Outcome Profile, which gives us a measure of the frequency of alcohol and drug use in the past month, as well as the typical quantity that people are using. And then there's a whole bunch of quality of life indicators in there as well, which were very important to clients. We're using the World Health Organization Assist measure as well. That gives us an overall measure of severity of substance use. So it tells us the frequency with which people are using different alcohol and drugs in the past 3 months, as well as the alcohol-related problems that they're experiencing. And that maps nicely under DSM criteria. So it gives us a good measure of severity and impact. Mental health is very important as well because of the high rates of comorbidity in this population. So we use the Patient Health Questionnaire 9. It's 9 items long and gives us a measure of depression symptoms in the past 2 weeks, including suicidal ideation. The anxiety is measured with a generalized anxiety disorder, which is a 7-item measure. And then there's psychosis screen and a PTSD screen that's only collected at service entry. And that tells us whether there's a positive screen for each of those disorder types, and then we intervene accordingly. There's also a gambling screen in there, measures of chronic pain, loneliness, and social measures around non-drug using friends. So it's quite comprehensive. It's quite lengthy, but clients are completing it quite happily, and all of the dimensions in there are covered that they wanted in there. So it's working quite well. And because the ATOP and the Assist were both delivered by interview in the validation studies, one of the first things we wanted to do was look at their reliability as an online self-report survey. So we interviewed 101 young people accessing one of Lives Live Well's residential treatment services. And we found that it was quite reliable, and as an online tool, both of them were. So anything above a 0.7 on this graph is a sign of at least moderate to high reliability. So everything had excellent levels of reliability on the ATOP and Assist. And there was moderate reliability for tobacco on the Assist and other opiates on the ATOP. So what we took from that was that the self-report measures being delivered directly to clients at service entry were working, and they were responding them in a valid and reliable way. The second thing we wanted to do was have a look at what was going on in the system itself and try and identify what some of the challenges that might be in the way of implementing outcome measures were. And so we did some interviews with clients and staff, and there was really no surprises there. Counsellors were saying things like clients won't complete outcome measures, they'll put them off from coming into treatment, they won't be able to do it by themselves, they want to come in and tell their story, they don't have emails and mobile phones, and they don't like technology, and we don't have time for any of this, which is fair enough because they really don't. Organisational barriers were things like trying to deliver outcome measures in paper and pencil without any scoring or feedback, lack of consensus around what measures were being used and when. Quite a lot of people measure outcomes at service entry, but then getting the follow-up data and giving feedback to clients is quite difficult and doesn't happen. So it's basically just that all the systems and supports and policies and procedures and training for implementing outcome measures were just non-existent. And at the system level, we've got funding models that focus on the number of clients who are enrolled in a program, not necessarily treated. And it's all about the quantity, not the quality or the outcomes for clients. And that's what happens in a system where there's huge demand and limited resourcing, which is what we're trying to do something about. In terms of the system itself, we were working a lot with Qualtrics online surveys in our research, and we're very confident in programming surveys into those instruments for things like the Assist that have quite a comprehensive skip structure. So we worked with LiveWell to develop a Qualtrics survey containing those outcome measures. And then those outcome measures were sent to clients at service entry. So when they're enrolled, they were sent. And then again, sent it 1 and 3 months later after they completed that service entry survey. It was all done via self-report. And once the survey is completed, the clinician receives an automatic email containing the client feedback, which looks like this. So this is the feedback that comes out of Qualtrics. You have to program it to do this. So you can see there that this is the Who Assist results. This person, I can't use my mouse because things happen, so I'm just going to have to talk. So for tobacco, there was no information there, but for other drugs, this person was using, on the ATOP, had used alcohol 12 days in the past 4 weeks and was typically using 7 standard drinks. So you get information on their patterns of use, what drugs they're using, and there's an example there of the anxiety feedback. So this person had a score of 7 on that anxiety measure, which meant that had a moderate level of anxiety. So the idea was that clinicians would use this feedback to talk to the client about their symptoms when they first came into treatment and use that to inform treatment planning, etc. So this didn't all happen overnight. So we started working together in 2017. It wasn't until about April 2020 when we actually got to the point where we were ready to send the outcome measures to clients, and we had the systems and processes set up to support it. So this was when we were sending the outcome measures at the point of enrolment. So this is typically when the client came in for their first session. They were all receiving Qualtrics feedback sent to staff. And then the counsellor was scheduling the 1 and 3 month follow-ups with the client. We then realised in the next 12 months that our follow-ups were just not being sent. So we ended up automatically scheduling the follow-ups to go out. So once the baseline was completed, there was an automatic scheduling for the 1 and 3 month to go out. So that made it easier for clinicians because they didn't have to send them. So that was another barrier we had to address. We also embedded some assistance there for the clients to complete the surveys, so they could reach out online or via phone if they needed assistance completing them. They were receiving 3 reminders to complete them if they forgot about them. And we also started following up active and inactive clients. So active clients, anyone that's been seen in the last month. So originally we were only following up people who were still in the service, but then we wanted to start looking at people who'd left to see what happened. And so we started following them up, even if they weren't seeing the service. And that's been really interesting from a clinical perspective, because it's been a great way of re-engaging clients who left abruptly or just didn't come back, they could do a survey and that would bring them back into treatment, which has been a great thing to see. So then we were brave enough about 6 months ago to start looking at some of this data, because we thought, we waited until May 2021 because the system was still so many moving parts, it was really unstable, the data. So then we looked at May 21 to November 22, so 17 months of data, and we wanted to see what was going on. It was very exciting until we looked at the data, and it's just the volume of data is huge. So there were 35,000 data points in this sample. So there's a lot of duplicates and errors and things in there. So Nina Pacuco, who's one of our postdocs, gallantly cleaned this data for about 4 to 6 months. And you can see there that by the time we cleaned out the duplicates, the errors, everything, we lost 56% of the data because it wasn't valid. So the final sample had about 15,000 data points in it. And this is the challenge of big data that we're all facing, is that when we collect outcome measure data like this, there's always going to be duplicates. Clients going to click the wrong survey. They're going to do it several times. There's quality issues, there's errors, there's missing data. Sometimes there's false data. The client journey is not simple. They don't all come in and stay in one service. They move around. And also the clinicians, human error happens. They mean well, they might schedule at the wrong time, they might cancel it incorrectly, and they might reschedule when the person's already got outcome measures going. So the poor client ends up being hit with lots of outcome measures and not knowing which ones to complete. So we've been working very hard to try and address those issues with Lives Live Well outcome measure team and IT team. So this is what we found. So this is a number of outcome measures completed across time between May 21 and November 2022. So there were 17,274 outcome measures sent in this time from 135 services. So if you look at the top line, you can see that 70% of outcome measures that were sent from all services were completed at baseline, 40% were completed at 1 month follow-up, and 22% were completed at 3 month follow-up. And we also had 35% of clients did not receive outcome measures. So that's for about 65% of the sample, those figures. And when we compare all services with the residential and outpatient services, we see that so the residential services are purple. So at service entry, the completion rate's a little bit higher, and primarily that's because you've got a captive audience. People are there, they can complete them, they can be encouraged to do so. But once we get to 1 month, the follow-up rates are pretty similar across both residential and outpatient services, and the same picture at 3 months. So it's consistently about 70% at service entry, 40% at 1 month, and about 22% at 3 months. We wanted to look at whether active status impacted on completion rates, and we found in fact it did, which is no surprise. So clients who were active, who are in purple, the people who'd been seen in the last month, were much more likely to complete the 1 month and the 3 month follow-up than those who were inactive. In fact, that people who were active had double the completion rate at 1 month and almost triple the completion rate at 3 months. So there's obviously a lot of work we've got to do there to try and get those completion rates up across the board, both in active clients, but especially inactive clients. And this is just showing you how it went over time. So it's May 21 to October 22. So 57% of people who inquired were enrolled in the service, and that was pretty stable. 69% who were sent the baseline measure completed it. Treatment was about 35% of clients who were enrolled attended at least one session of treatment. About 19% attended 2 sessions and 21% attended 3 sessions. And the same pattern with the outcome measures. So they're pretty stable over time. There's ups and downs, but overall it's about 70, 40, 20 over time. So in summary, we were able to identify some core outcome measures, implement them using an online system, provide feedback to clients. So this very much increased the capacity of Lives Live Well service to assess client outcomes. And I've said the figures before, it's about 70, 40, 20 in terms of the follow-up rates over time. They're pretty stable over time. They're consistent across outpatient residential services at follow-up, and active clients are much more likely to complete them than inactive clients. So in terms of looking at some of those challenges, we can see that there was concerns that clients won't be able to complete baseline outcome measures by themselves, or wouldn't be willing to do so. And we can see from that data that at baseline, 70% of the people who were sent them did complete them. Not all people were sent them at baseline, which is something we've addressed. So that has gone up a lot in the last 2 years or so. We found that clients do not disengage from service if we send them outcome measures. There's been no reduction in the number of inquiries who enroll in the service, and 35% of them have attended at least one treatment session, which has been pretty standard practice. But we have got some issues there with follow-up measures about we need to try and increase the uptake of those, particularly at follow-up and with those inactive clients. What about the client outcomes though? So this is the actual outcomes from the data where we've spent 6 months cleaning. Thanks, Nina. Problem is when we look at this, we have to match the baseline data with the 1 month data. So when we do that, the sample goes down to 2,832. So 41% of clients who came through the service in that time had baseline and 1 month data. And when we look at baseline 1 and 3 months, it goes down again. So 1,027 people, or 15% of the sample, had 3 data points. So luckily the mean scores at baseline and between baseline and 1 month in both the baseline and 1 month data set and the 3 data point data sets are pretty similar. So I'm just going to talk about the 3 data points today. So we look at the ASSIST total score for alcohol, methamphetamine, and cannabis. You can see there that the black line below that, it's very jumpy. You can see that at alcohol went down from a score of about 18 down to 14. So anyone above that line requires a brief intervention. These are mean scores. There will be individuals with really high scores, but and you can see in the methamphetamine and cannabis as well, we did get reductions in the severity of their substance use and related problems in the past 3 months between baseline and 3 months. In terms of the mean number of days people use drugs in the past month, similar picture. So alcohol went down from a mean of 9 days in the past month down to 6. And methamphetamine went down in terms of the number of days, and so did cannabis. But the interesting thing here, and all these differences will be significant because it's such a large sample. When we actually look at the quantity at which people are using the drugs rather than the frequency, this is where we really see the effects. And this is where we've always seen our effects in clinical trials. It's not the frequency, it's the quantity that goes down. So this is typical alcohol use in the past month in standard drinks. You can see this that the mean has gone down from 12 to about 7. Not much change between 1 and 3 months, but still a pretty good reduction there in the quantity that people are using when they do use. And there's a similar picture of a typical methamphetamine and cannabis quantity. This is standard grams. So we actually clean the data, so we're actually standardizing it so we can talk in grams for specific drugs. So anyone who was using these drugs when they first came into treatment, we can see that the amount of methamphetamine they were using pretty much halved and stayed in half at 3 months. And a similar picture for cannabis, it did go down and stayed down, but there seems to be the reduction, the 1 to 3 months doesn't seem, but at least people are maintaining the low levels of use at that point and haven't gone back to service entry levels. And we look at depression. You can see here that when people come in, they tend to have moderate to severe levels of depression. By 1 month, it's in that mild to moderate range, and it stays there at 3 months. And it's a very similar picture for anxiety. They come in moderate to moderate severe, and then it goes down to still above moderate, but still there. And that's because we do find very high rates of PTSD in our sample. There's still heaps of questions we haven't answered. So once again, how do we get these follow-up rates up for outcome measures? What happens if we send them before enrollment? What happens if we provide client feedback? At the moment, we're just providing staff feedback. What if we make the feedback comprehensive, including normative data, visually appealing, and give them progress mapping so they can see their change over time? And what if we link the feedback to fact sheets and harm-in sheets and other resources, so that maybe that just doing that survey and getting that feedback and looking at that resources might be enough for some clients to keep them going for a while they wait to get into treatment or decide not to come in at all. And this is where we go into phase 2 of our project, because we wanted to answer those questions. So what we did is we built a new website called Quick Fix that actually standardizes the scores from the measures and creates a feedback report for both staff and clients. It also gives us progress mapping over time, so it shows clients how their symptoms are changing over time. And it also contains a built-in brief intervention that we've used in numerous clinical trials. We did a trial across 4 outpatient services over the last couple of years, implementing a brief intervention called First Step, and then we actually looked at sustainability over 12 months after that to see if the service continued to deliver outcome measures and the brief interventions once the research team, us, pulled out. This is just to show you what the website looks like. It's freely available. It's funded by the Commonwealth Department of Health. It can provide a feedback report on any outcome measure at any time point. It's very flexible. So it's purpose built for that purpose. So if anyone wants to use it, please contact me. And this is the process itself. Clinicians send the outcome measure to clients. They complete it. It goes to the website. It generates the feedback reports. And then for both the clinician and the counsellor, and it's all sent through the service. So we're not touching client data at all. This is what the feedback looks like. So this is the feedback that clinicians receive. So this tells us what drugs people have used in the past 3 months from the assist and how frequently they reported using that. They're asked to nominate what their primary drug is. And in this case, it was methamphetamine. So then they're given feedback on how their methamphetamine use compares to national Australian data for their sex and age. They're then given some feedback on how many days they reported using their top 3 drugs that they chose in the past month, the amount they typically reported using in that time frame. There's a WHO Assist total score feedback down the bottom there for a range of drugs. The clients don't see that part. There's a whole range of risk behaviours that are asked through the assist, and some other questions we've added. So we give the clinicians feedback on what risk behaviours people are engaging in and how often. This is the feedback that people receive on depression. So they receive feedback on depression, anxiety, the severity of it, and how many other people their age and sex are experiencing that from normative data. Clinicians receive feedback on whether the client reported suicidal thoughts, a history of trauma, and it has a likely positive screen for PTSD, as well as psychosis and some information on chronic pain. This is the psychosocial data. So it reports how much time people spend with non-drug using friends, what kind of issues they've had in the last 4 weeks in terms of housing, what's happening with children, violence, corrections and hospital stays, their physical health, and just their overall quality of life rating. So the client doesn't get any of that demographic stuff because we don't need to tell them that stuff because they know that. This is what the progress chart looks like. So this is interactive. So the client and the clinician receive the feedback. And when they look at the progress chart, if they click on a different drug, they can see how they're tracking on that drug over time and turn drugs on and off, so they can see what's happening to their substance use on multiple substances. They get feedback on the amount they've typically been using over time. And like I said before, that's where we see the most change. And we've also given them feedback on how severe their depression and anxiety symptoms are. In terms of the proportion of clients who requested assistance completing this outcome measure, we found that about 94% of them completed it online by themselves, and about 5 to 6% responded yes, they completed it with a counsellor. So they could contact the service and say they wanted to do it face-to-face or over the phone with a counsellor, or just do it by themselves. Most people did it by themselves. So the difference with this study as well, I'm not sure if I mentioned it or not, was that outcome measures were centred inquiry, not enrolment, because we wanted to see if that had an impact on how many people enrolled, and if it had an impact on clinicians' time and their capacity to deliver treatment. And we found that it did. So that left column is the other outpatient data I've reported before between May 21 and November 22. The purple column is this pilot study during the research trial, and the green column is the sustainability for 12 months after we finished the trial. So you can see the proportion of outcome measures completed that were sent didn't really change when we sent it at inquiry before they had any contact with any clinician, rather than enrolment. We found that it didn't really impact on the proportion of clients who inquired, who actually enrolled. That was pretty stable over time. Where we did see a big difference was the proportion of enrolments who received treatment. So we saw 35% in our other outpatient data, but in this sample it went up to 82%, which is interesting. And we're not really sure what's behind that. That could be putting outcome measures at the front end of the service resulted in more motivated clients coming into the services to start with, who are more likely to go into treatment. It could be the first step group intervention itself, or it could actually just be the role of the outcome measures with feedback having an impact. It's hard to know. That's something we need to look in further. That the people in the first step study were also receiving that feedback, which is the quick fix feedback I just showed you, rather than the original Qualtrics feedback, which was just the black and white boxes and things like that. So that may have been a factor as well. And you can see that the outcome measure follow-up rate and the other outpatient and first step during sustainability is pretty similar. The follow-up rate during the implementation trial, so 1 month, 81%, 3 months, 64%. That's when my team of research assistants are chasing people. So I reckon that's probably the best it can get. So even, so that's kind of would be a challenge to get to in a real world setting without a team of research assistants chasing people. But it's good to know what the top level is probably like. So we look at what myths we've busted with this trial. We can see that clients can complete outcome measures by themselves. Only 5% of them needed help. And while it's true that clinicians don't really have time to deliver outcome measures to clients, we found that clients are more than happy to do these measures online, and giving the clinicians a feedback report hopefully increases the amount of feedback that's being given to clients. And we're hoping that hopefully this is saving clinicians some valuable time by only enrolling the people who complete the baseline outcome measures to actually get into delivering treatment more with the clients that are enrolled in the service, rather than spending a lot of time trying to chase down and enroll clients who perhaps were never going to come to treatment or are going to come at a different time. And we also found that sending outcome measures of inquiry rather than enrolment had no impact on the number of people who came into treatment. So we think that's all a positive thing. So to conclude, I guess when we deliver these outcome measures of inquiry and we offer clients a brief intervention, we find 60% of clients complete that baseline measure, and that compares to 70% in the other setting in enrolment, so pretty similar. But we see a massive increase in number of getting into treatment. And as I said, we're not sure what that's about yet, so we need to look into that more. The good thing is that this first step intervention was sustained in its delivery over time in terms of outcome measure completion, enrolments and treatment rates, which is a positive. So now we're actually doing a large cluster research randomized controlled trial, rolling first step out across all Lives Live Well services. That's happening this year across 8 regions, in Queensland and New South Wales across 62 drug and alcohol programs, 200 clinicians and probably about 9,000 clients. We're also expanding it to withdrawal day program residential programs. The first step training includes training and feedback and progress mapping for clinicians. And we finally turned on the automatic client feedback and progress mapping. So it's everything we've done prior, including the first step trial. We have only had clinician feedback. So we're now sending it to clients as well. So we're really going to see what happens when we do that, where that increases the rates of follow-up in clients when they get immediate feedback on on the survey they've just completed. Other projects we're doing as part, we're lucky enough to get a NHMRC Centre for Research Excellence a couple of years ago, and it's all about outcome measures. It's called the Meaningful Outcomes Substance Use Treatment, CRE. We're doing a big discrete choice experiment where we've done a whole bunch of interviews with clients and staff around trying to figure out what would increase the likelihood of them completing follow-up measures at both at baseline, but also at follow-up. And we're trying to engage people from the government and non-government sector for New South Wales and Queensland to try and help us answer that question. We've got a big data linkage study planned where we're going to link core outcome measure data with long-term data linkage data, and then use this massive data set and machine learning to try and understand which treatments respond to which clients respond to which treatments, and also monitoring people's recovery over time and when people are on track and off track. So we can try and develop some decision support tools to help with treatment planning and outcome monitoring over time. So lots going on. Just wanting to acknowledge the huge team of people who are engaged with the Meaningful Outcomes CRE, who are all listed there, as well as our partners at Lives Live Well, some of whom are on there as well. So thank you.
Hi, wow, well done, Leanne. That was a fantastic presentation. I've written down half a page of notes. Really great. I mean, it's so exciting to see data being used in this way and really closing that loop, giving it back to clinicians and giving it back to clients as well. I had a bunch of questions that you then went on to answer, so I've scribbled them out. But so thanks. That was a really great presentation. I love that idea of having, you know, immediate feedback to clients. I think it's something that we all kind of relish on. I don't know who's got a Strava account, but, you know, like everyone's counting steps and you want that kind of feedback. It really gives you something to think about and work with. So I think that's a really neat idea. So just before I'll open up to questions, we've had a few come through, which we'll try to get to. I just want to welcome Dr. Robert Sterling and ask him to thanks, Rob. Hi, welcome. So Rob is the CEO of NADA. So this is the Network of Alcohol and Other Drug Agencies. He's worked in the centre for over 20 years and has done a bunch of work recently on performance measures in the sector. So welcome, Rob. Thanks so much for making some time to join us. I appreciate your time. I'll start just by throwing to you, if that's okay, Rob, and asking if you had any reflections or anything you wanted to add at this point before we go to questions.
Can't hear you, Rob.
I can see you talking, but I can't quite hear you. No, sorry. Oh, we even practiced this before and it worked perfectly. As is always the way. Perhaps I'll give you a moment, Rob, just chime in if you get it working, and I'll just throw it. Oh, there you go. You're back.
Sorry about that. Technical
That's
issues. Thanks, Sarah. Thanks, Leanne. That was great. I mean, I've heard about the work that you're doing with Lives Live Well. So I think first, I mean, I think it's awesome, the partnership that you have with Lives Live Well, and it would be great to see more collaborations across the sector. I mean, I think for me, it's all very familiar in terms of the outcome collection. We've been supporting non-government services in New South Wales to do it for the past 10 years. So a lot of the challenges that you talked about, very similar to NGOs in New South Wales. And I was just thinking about the comment you made around data quality and cleaning, and thinking about all those services who don't have a research assistant or a data support person or a NADA-based support person that we help. I know I had a national consult recently, and they were talking about how do we improve things, and it doesn't happen without that support. I think that's a real take-home message that I have, is that data collection is really challenging. Most clinicians want to be doing the front-facing work. They want to be working with people. And so how can we support people to do the work that they want to do with people? And so for me, the take-homes around the work that you're doing around feedback is really taking it to the next level, and that real-time feedback, but also the online collection, the client interface of getting people to collect data, to do the outcomes themselves, is definitely, I think, something that we need to learn and expand out to other services, because we definitely find the same trend of intake and then the drop down and then the drop down again. I know there's lots of questions, and I actually had more questions than anything as well. I mean, I'm really interested about this time from inquiry to entry to service. Is there any challenges of people doing an outcome measure and there's a delay? Like, we know a lot of our services have wait time to get into treatment. Is there any issue around there being a delay of intake? And the other question, which is related, is around the time point. So we're doing baseline and then 1 and 3 months. So, I mean, I know a lot of funders like to have an exit survey. What were the discussions that informed those decisions?
So the exit survey, I guess the issue that because I think Lives Live Well used to do that, and the issue was that they just weren't getting any, because when people exit the service, it's rarely planned, and it's sometimes people just fade off. They miss an appointment, and then if everything's being done face to face, and then they're never coming back again, how are you going to get that exit survey? And in Resi, people often leave quite abruptly, not always under the best circumstances. So it's kind of the worst time to be trying to get feedback from someone, particularly about their treatment journey. So, so what, we toyed with the time frames, and we just went with what the measures did best. And so if they stay more than 3 months, then they'll get another survey at 3 months. So it can stretch out as well. So it can go either way. What was your first question? Sorry.
The time between inquiry to entry into a service, so there might be quite a lag in between if there's a wait time.
In our pilot study, the clinicians worked very hard to try and make that not very long at all, because we were basically, you've got to, if they're coming into treatment, you need to get them in quickly, because we're early in that help-seeking episode. They've gone to the effort to complete a survey, and these guys weren't getting feedback, so they weren't getting anything until they saw the staff member. Even after doing this big survey for us. So they worked very hard to do that very quickly, and they did a pretty good job of it. But of course, there's always going to be problems. And Steve Sinclair, who was the team leader, also tried a whole bunch of things like putting time in their diaries to put these patients in, so that there was no lag. So, but I think it's unavoidable. But there are ways you can manage it. And I think having the client feedback turned on, at least the clients get something immediately back. So they're still engaged, essentially.
I'm going to steal another follow-up question. Sorry, Sarah, I'm jumping in your job, but I just had a question about, so if someone completes an outcome tool at that inquiry stage and it shows like high psychological distress, or that do they get escalated into treatment quicker with Lives Live Well?
Yeah, so there's an alert system. So if someone comes up at suicide risk, or really high on depression, or DV, that kind of thing, there is a risk alert that goes into their system that brings it to the attention of the clinician. And that also happens at follow-up. So even if the client's inactive and they do a follow-up and they get flagged for suicide risk, the system then creates an alert to let the clinician know, or someone else in their team know that that person needs to be followed up. It's tricky though, because, you've got close cases, and then they come up as a risk alert. It's hard, it's hard to manage that. But I think Holly Stokes at Lives Live Well has been doing a fantastic job of trying to manage that process, and, try and and they found the feedback that we've got from staff is that they actually quite like it, because it's a great time to re-engage people that have perhaps faded away or dropped out. It's almost like a help-seeking attempt filling out the survey, and then if it's followed up with the service going, "Hey, are you okay?" It's a really great way to bring them back in.
That's awesome. I'll hand over to Sarah now. Thank you.
Oh, that's great. That's a great question, Rob. Leanne, I'll just get you to stop sharing screen if you can, so that we can see your big faces.
Oh, no.
That's better. Perfect. Thanks. So I'll jump into questions now that we've had from participants. So the first one says, thanks, Leanne, great project. So obviously there's some limitations on how much we can infer between the pre and post outcome data, but wondering about how else we might be able to use that data. So have you looked at, looking at characteristics of treatment or treatment engagement to see if there are particular characteristics that might be associated with better or worse outcomes? I guess they're kind of getting at, how that we might be able to predict.
Yeah.
You got to that a little bit with the machine learning work, but yeah, maybe you can talk to that again.
Oh, absolutely. And, we're more frustrated than anyone. Like, we've been setting this up since 2017 and it's 2023, and we've finally got some data that we know is clean and valid and reliable. So there's so many questions that we have, and they are some of them, about, like, we only looked at those outcome graphs yesterday, and it's so exciting to see it because, it's been so long coming. But there's endless possibilities of what we can do with it. And that's the beauty of the data itself. Obviously, we need to get the outcome follow-up measures completion rates up to make it more meaningful in terms of having more data on people over time. But that's what the CRE is trying to do, is doing a series of projects, just trying to engage clients and doing those follow-up themselves, and hopefully staff as well to help us do that.
Yeah, that's great. Yeah, the world is your oyster with this sort of rich data and the data linkage stuff as well. So then linking it back to other things, that's great, really exciting. The next question, sort of similarly, is asking about whether you collected any data or analysed it by ethnicity, and if there were any important characteristic changes, I guess, between different groups.
We have that data? We haven't done it yet. Like, it's honestly been like, I was madly trying to get it ready for the NADA conference last week. This one this week, and I was like, I've got to show some outcome data. And poor Nina, I've been like sending her all these questions, and she's probably had enough. Yeah, but that was so many things that we want to do. And this is just the start of it, really. Yeah. No, that makes sense. Okay, so the next one, it's from Jennifer Holmes, and she's asking, she said, thanks, Leanne, for the quantity feedback, did the program clean the data and convert it to grams? Was that one of the cleaning steps? No, what we do is we have it programmed so the client can pick what level of measurement they want to use. So, and last resort, they just write it if it doesn't work for them. And then our research team then convert it, mostly manually. It's not a great job. It's tricky.
That's really...
particularly with GHB at the moment, different ways it's being used. We're just coming up with these bizarre questions that we never thought we'd be asking. So they do a fantastic job, and we keep really clear set of rules. And the main thing is it's consistent. So we're just constantly trying to just use that standard consistent criteria, just so we're combining like with like over time. But it is tricky. And that's going to be the hardest thing to automate in the future moving forward. But that quantity data is so rich because, like I keep saying, that's where we see the change, because frequency, you can drop 3 days, but which is not much, but if you drop 3 grams, that's great. Yeah,
that's right. I hadn't realized that. That was really interesting. You pointed that out, that the quantity versus quality, quantity work versus frequency idea. I hadn't heard that before. Yes, it's interesting. Yeah. Okay, so I'll keep getting through these questions. So we've got another one about the outcome measures, and you talked a little bit about the DCE, which is great. That's really exciting. So this question's about, have you used any of the outcome measures in cost effectiveness studies?
Yes, but not in this context yet. So that's sort of one of the other aims of the CRE is we're looking at trying to increase value-based healthcare. We're wanting to make it more cost effective, efficient, and actually efficacious for clients. So it's part of the process. It's not the central element though. We're more interested in the actual outcomes themselves, but we do have that data. If there's anyone who wants to work with us to help us analyze that data, that'd be great. We're looking for a health economics PhD student or a health economist that wants to work with us, because we've got truckloads of data and we need someone to help us.
I'm sure you won't have any problems finding people to work with. It's really exciting.
I also wanted to acknowledge the role of NADA in all this. I mean, the work that Rob and Pete Kelly have done with NADA Base has been very inspiring, and they were leading the way in this field. So we kind of came along and as the new kids and just learned a lot from what they're doing. And it's great that we're all working together now to try and move this forward so that everyone can benefit.
Absolutely. Thanks, Liam.
Yeah, it's great. I mean, we're all on the same team, right?
That's right.
There's plenty of work to go around. So
yeah, plenty of work done.
Yeah, that's it. And I mean, I think that's like one of the nice things about your presentation is seeing a really successful relationship between service providers and you know, academics. Like, how can we work together to try and get something that's useful? I think that's a really nice example of that. Okay, so the next question is from Patricia Morton, and she said, thank you, very interesting presentation. You were clear about how the data could be used to inform patient care and to understand what is happening at a population level. Can you tell us whether or how you've used it as for service level or system level performance? So I guess that's sort of getting to, you know, what do we do as Lives Live Well? Is there anything that we need to look at or change based on these outcome measures?
Yeah, I guess the main one we've been looking at is increasing efficiencies for workers in terms of not making them work harder or faster, more about how we can use technology to reduce their workload, which is why we went for client self-report data, because, you know, clinicians have been saying, I've been doing outcome measures for like nearly 30 years, and I've consistently heard we don't have time. And I've been a clinician myself and found I don't have time either. So we finally listened and went, let's just get the clients to do it. And if we automate the scoring and the feedback, then some of the work we're doing at Lives Live Well is sort of using the feedback that we get from the Quick Fix website basically as the intake to deliver the brief intervention, so they don't have to do a psychosocial assessment before they get into treatment, because we want to bring people in as fast as we can and give them treatment straight away, because we know that most of them only come once or twice. So spending 2 hours doing an assessment and then they're never coming back again is not useful use of time. So we'd rather them come in with their measures done so we can talk about the feedback and then come up with a treatment plan and get straight into treatment. You know, we don't have any data to back this up yet, but from what we're seeing, it seems to be increasing the treatment rates. So 35% versus 80%. We don't know what it's about yet, but we think it's the efficiencies. And I think just freeing up clinicians from admin time and giving them time to do treatment, which is what they want to do. And technology can really enable that.
I had the same question as Patricia, because I'm thinking about this: collect data once, use it many times. And obviously client outcome tools are developed to be used between the clinician and the person, but how can we use that aggregate data to inform service improvement? And then the other part of Patricia's question is, how do we tell that story to funders as well to demonstrate that the value? You talked about values-based healthcare earlier and making that connection with using that aggregate data to tell a story about performance.
Yeah, it's tricky. I wrote a fellowship application and I was trying to articulate this and it's not easy. So you kind of have to get the staffing profile and the caseloads data and all this sort of stuff and try and map their time. It's tricky. How do you measure efficiency? And there's a whole field of research in it that I don't know anything about. So if anyone wants to tell me, that would be great, because we're still trying to figure that out. But from what we can see, automating some stuff and making clinicians' lives easier is increasing treatment rates for clients. They might not be related at all, but we've got to find a way to show that they might be.
Can I jump in again, Sarah? Because we talked about values-based healthcare. So the other part of that is experience and clinician experience, and the person has your project been looking at those elements of values-based healthcare as well?
Yeah, so after the pilot trial of First Step, we did a bunch of interviews with staff and clients about the experience and what they found, and they did a bit of a little survey for us. It was only like 13 clinicians and it was something like 45 clients. And it was interesting in the clients were more open to outcome measures and brief interventions than perhaps the clinicians were. And it was quite interesting that was still present, because it was there beforehand. It was still present after the trial itself. So it sounds like we've still got some work to do around convincing clinicians that a brief structured intervention at the front end of the service can be beneficial for clients. The clients are saying they are. The outcome measure data we have from the trial shows really positive outcomes. I didn't have time to show it today. And this cluster RCT we're doing at the moment will actually tell us that. It will tell us whether getting this treatment at the front end of the service and in completing outcome measures before enrolment, did the people who've got that, did they have better outcomes than the people that weren't getting it? So we'll know probably in 12 months or so.
Yeah, no, that's great. I mean, you know, it's really just the beginning, right? Like you've
Yeah.
done all this, you know, 6 or 7 years of work to get it set up. And now you're sort of at this stage where you can really start to play with some of these really interesting ideas. It's fantastic. We're just about out of time, and there's a couple more questions here that we haven't got to, I'm afraid, but perhaps we'll just tackle one and then we'll wrap, and I'll just encourage other people with questions to get in touch with Leanne and track her down, and I'm sure she'd be happy to chat with you about it. So just a quick one here. There's one question about did any of the outcome measures or any of the tools that you used include any questions around memory or cognition or cognitive complaints? No, not covered. Yeah, okay.
I mean, that's something that I think is better asked face to face. Plus you want to be doing some MSc assessment face to face anyway, or over the phone, but yeah.
Yeah, sure. Okay.
Sure, there's measures out there that can do it, but it's, you know, this is a screening tool and an outcome tool. So I think, yeah.
Yeah, no, that's great. Thanks. Yeah, I mean, it's really interesting. I think, you know, I really liked your busted myths section, you know, this idea that clients won't do it, that they can't do it. And just to show, you know, that there was actually only a handful of people that asked for assistance, and by and large clients could do it. You know, it gives more sort of purchase and ownership to the clients as well. So it's got a range of benefits beyond just the, you know, the data, I think.
They really want the feedback and the progress charts, and
yeah,
find a way to, you know, so now we're getting them straight to them. We're hoping that's going to improve things even more for them.
Yeah, no, that's great. Excellent. Well, thank you very much, Leanne and Rob. It's been a really interesting discussion this afternoon. I really appreciated both of your time, and I'm sure we've all learnt a lot. So join me in thanking our presenter and our panelists for today's discussion. I'll just quickly flag before we wrap for the day our upcoming webinars over the next couple of weeks. We've got 3 coming up over the next few weeks that are really exciting. Next week, we're going to be joined by Dr. Nicholas Taylor, and he's going to be presenting information on minimum unit pricing of alcohol in the Northern Territory. And then the week after, we've got, on the 8th of June, we'll have Dr. Amelia Woods talking about extended release pharmacotherapies for substance use disorders in